Multiple sclerosis is the most common immune-mediated inflammatory condition of the central nervous system. The inflammation causes lymphocytes to trigger demyelination of myelin and axons, which impairs the conduction of fast nerve signals, therefore accounting for most signs and symptoms. This happens when autoreactive lymphocytes invade the CNS by crossing blood-brain barrier and form plaques, causing progressive damage. The inflammation also destroys oligodendrocytes, which secrete myelin sheath. Myelin sheath is responsible for insulation of nerve impulses and proper communication around the body. Damage to myelin sheath therefore impairs the most basic cognitive and physical functions of the body. The signs and symptoms appear as a rapid onset of cognitive, sensory, and physical disturbances. Lesions can be present within any parts of the CNS such as cerebellum, cerebral pathways, optic nerves, brainstem, and spinal cord. Multiple sclerosis within the cerebrum lead to cognitive impairment, motor deficits, depression, and epilepsy. Signs include attention deficits, reasoning, and dementia. MS within the optic nerve damages sight directly. Damage to myelin sheath lead to unilateral painless loss of vision, reduced color vision, scotoma, as well as pupillary defect. MS within the brainstem impairs nerve impulses from the rest of the body, leading to clumsiness, poor balance, impaired speech and swallowing, as well as diplopia. Loss of axons lead to signs of limb incoordination, gait ataxia, and dysarthria. MS damage to the spinal cord leads to upper motor neuron spasticity, weakness, stiffness, and erectile impotence. Conduction block due to axonal degeneration leads directly to bladder dysfunction as it impairs coordination between peripheral nervous system and cerebral cortex. More than 80% of patients diagnosed with MS experience bladder complications. Furthermore, fatigue, temperature sensitivity, and exercise intolerance are caused by conduction block in the nerve pathways, exacerbating neurologic signs and symptoms, diminishing physical and cognitive function. Multiple sclerosis can be classified into 4 subtypes determined by disease activity and progression. Clinically isolated syndrome reflects the first episode of MS without previous history of the disease. The syndrome develops acutely within 24 hours without recovery. Relapsing remitting MS is defined with common signs and symptoms, followed by periods of remission. This subtype makes up 85% of all MS cases. Relapsing remitting usually occurs within the same location. Secondary progressives characterized by initial relapsing remitting with gradual worsening of signs and symptoms. Finally, primary progressive MS represents 10% of all cases, usually characterized by consistent accumulation of signs and symptoms from the initial onset of clinically isolated syndrome.
After identifying the clinical manifestations that could possibly indicate MS, a series of tests may be done. These tests include blood test, visual evoked potentials, CSF testing, and MRI. These assist in determining if an individual has MS or if they have another inflammatory disease which presents in a similar way, such as Lyme disease. Blood tests will likely be done in the beginning of an individual's initial workup after they present to their primary care physician with signs or symptoms that may be MS or another autoimmune disease. There are no specific blood tests that can diagnose MS, but rather tests that check for the presence or absence of certain autoimmune markers or biomarkers, such as anti-nuclear antibodies. The main role of blood tests is to rule out other diseases that may have similar clinical manifestations. Further testing and investigation will need to be done after blood tests before a diagnosis of MS can be made. Visual evoked response is a non-invasive technique that records the electrical signals which are produced by the nervous system in response to a stimulus. The test involves having a patient sit in front of a television screen with flashing lights and an EEG attached to the patient to record electrical activity. Most patients with MS present with a delayed visual evoked response, which indicates lesions typical of MS. An individual's CSF may also be tested through the use of a spinal tap. A sample of the clear fluid is tested for the presence of oligoclonal bands and immunoglobulin G. Typically, the presence of 2 or more oligoclonal bands in the CSF, but an absence in the serum, represents a positive MS diagnosis. This is found in approximately 90% of individuals with MS. An MRI is the most important diagnostic tool in diagnosing MS and monitors lesions growing and spreading. 3 types of MRI scans are commonly used, each showing the anatomy of the CNS in different ways. T1-weighted scans show the CSF as black, which is useful in showing the anatomy of the CNS. T2-weighted MRIs show the CSF as white, which can be useful for differentiating pathology. Fluid-attenuated inversion recover produces images with CSF as black and plaques appear as white. Through the use of MRIs, dissemination in space and dissemination in time can be detected. Dissemination in space can be detected early, although only when there are 2 lesions in at least 2 MS-typical locations. Dissemination in time refers to the development of new lesions over time. However, a diagnosis of MS can be made without proof of dissemination in time if the individual has evidence of dissemination in space and a positive CSF result.
In 2011, there's been roughly 13,000 people in Australia with MS. 73% of these were female. In the 8 years since 2011, this has increased to around 25,600. Worldwide, MS has increased from 2.1 million in 2008 to 2.3 million in 2013. The generally accepted view is that MS tends to be more prevalent in predominantly white, well-off countries and brown third world and tropical zones. MS also appears to be common in Caucasians who have Northern European ancestries. Studies show that it is rare for Aboriginal, Maori, or Torres Strait Islander peoples to have MS. Although there has been an increased incidence in women with late onset, there has been only a small increase in men. Even though there is not a definitive cause of MS, research has identified possible causes that can hasten the onset of the condition. MS is not a condition that people are born with. These factors that affect the onset and severity of the disease are characterized in 3 subheadings: genetics, environmental, geography. Northern European populations have a genetic predisposition to MS. Other groups such as Sami peoples and Aboriginal seem to have the protective genes. The environmental risk factors for the development of MS include the Epstein-Barr virus, smoking, teenage obesity, viral infections, and being female. Multiple studies have examined the incidence of MS according to the geographical location. Vitamin D exposure and latitude seem to be the impact of possibly getting MS. Higher serum vitamin D levels are associated with lower MS incidence, and a lower deficiency in vitamin D is linked to a lower relapsing. Socioeconomic status impacts many diseases, however, there is no clear evidence that affects MS. Life expectancy for patients with MS is approximately 7 years shorter than those for people without the disease. MS prognosis centers on the quality of life and disability of the patient. Studies show that after 15 years after the onset of MS, about 20% of patients end up bedridden, another 20% ends up requiring walking aids, while 60% requires no walking aids.
Patient management and care. MS is a chronic neurological disease affecting the CNS. Having no cure, the nurse's goal is symptom management. Managing the patient's impaired cognitive state is enhanced in collaboration with neurologists, social workers, and occupational therapists, creating a patient-centered care plan to alleviate stress and fatigue. Examples include peer support group therapy. Having patient involvement with other patients experiencing the same conditions normalizes the healing process. CBT and SSRIs, incorporated in the patient's lifestyle as prescribed through the allied health team to control depressive states. The goal of managing spasticity is to stabilize physical control, strengthen muscle groups, and improve posture. Having ongoing care through physiotherapists use aerobic and range of movement exercises to manage ataxia. Referring patients to speech pathologists to manage dysarthria is also key in managing communication and facial abnormalities associated with MS. Central neuropathic pain is a prominent factor of care. Medications managing this include the following as seen: anticonvulsants for treating trigeminal neuralgia and painful tonic spasms consisting of cramping and pulling pains. Neurological side effects include dizziness, drowsiness, headaches, and anxiety. Nurses should emphasize the risks and benefits prior to pharmacological treatment for patients to make an informed decision. Urinary incontinence management is associated with MS effects on the spinal cord. PVR evaluates the level of incontinence, urine abnormalities, and infections assessed via daily body weights, fluid balance charting, ultrasounds, bowel screenings, and MSUs. PVR below 100 ml highlights an overactive bladder, and PVR above 100 ml shows a lack of urine output. Short term, nurses can use clean intermittent self-catheterization, teaching the patients and carers the correct sterile technique to minimize infection. Long term, nurses can use suprapubic urinary catheter insertion to minimize ongoing urethral damage. Managing sleep and fatigue is done through modafinil therapy, stimulating the CNS to reduce the reuptake of noradrenaline in the hypothalamus. Nurses can facilitate this through creating a patient-centered environment with help from OTs and dietitians to increase melatonin exposure and incorporate a vitamin-rich diet to enhance the patient's health outcome. Relapse management is achieved through corticosteroid therapy, having immunosuppressant and anti-inflammatory roles to reduce short-term symptoms of relapse within the first 5 weeks. Benefits of oral corticosteroids include ease of starting treatment, minimal home and hospital care, and lower treatment costs relative to IV therapy. Plasmapheresis is a therapeutic plasma exchange used with other treatments when corticosteroid therapy is not as effective. Disease-modifying therapies aim to reduce symptoms, quantity of relapses, and disease progression. Relapsing remitting MS treatment includes interferon beta-1A and interferon beta-1B, as well as GA therapy, having nurses train patients self-injection techniques to facilitate long-term self-care. Nurses evaluate and provide feedback, enhance and update patients on the current immunomodulating therapy, highlight the correct injection technique to prevent redness and necrosis of tissue at the injection site, safe drug reconstitution, and to report and manage side effects such as headaches, chills, and fevers.